Welcome. Today we're going to talk a little bit about clinical lab studies. Sometimes we forget how important a clinical lab study is for our patients. And so we're going to take a look at some of them and we're going to take a look at some of their values. We're going to start off rather easy. We're going to talk about blood. We're going to look at the formed elements in the blood. What do they do for us? And we're going to talk a little bit about electrolytes. And the next lecture will actually be more about electrolytes and what they can do for us. So there you see, we do need those clinical lab studies. Some of them that we use are venous blood. We're starting to see a lot of VBGs out there. VBGs are good to give us information about your CO2. Not quite as good about the PaO2, but they still do that on occasions. We can do body fluids. We can also do secretions. Sometimes with our blood gas machine, we can run ammonia levels for patients who are in liver failure. We can also run pleural fluid if we do a pleurodesis or something, or thoracentesis or something like that. We can run it through there and see what's going on with it. So it's just a matter of what the physicians want and what our machines are set up to do. So there you see with blood, you've seen all of this before. Remember, with your blood, you have red blood cells, white blood cells, and then you also have your platelets. Remember, if you were to centrifuge the blood sample, you would see about 45% of it is red blood cells, that's your hematocrit, and about 55% of it is plasma. Plasma is mainly made up of water. You really need the plasma because the plasma carries everything. It carries your red blood cells, white blood cells, all your food, your feces. If you think about it that way, your waste products, anything else that you have to carry, it's going to be in there somewhere along the line. The platelets and white blood cells, teeny tiny little part. It's like a buffy coat that you'll see with these. So with blood, if you remember from semester 1, it's a liquid tissue. It's a connective tissue. There's two major components in blood, the formed elements, and then plasma. And plasma carries the erythrocytes, the thrombocytes, and the leukocytes. And those are your red blood cells, platelets, and white blood cells. Now, with the elements within, or the formed elements within plasma too, if we break out the white blood cells, there's actually 5 white blood cells, and sometimes you'll see that there's 7 formed elements. If they don't, then there's only 3, and that is just lumping all the white blood cells together. If you look at sometimes where they do the charting with the nurses and sometimes the physicians, if they're doing any hand charting, they use what's called fishbone charting. And if you knew what they were charting, then you could tell what the values were. And this is the one they use for your white blood cells, your hematocrit, your hemoglobin, and then your platelet counts. And this is a picture. It's an electron microscope picture of a white blood cell. You can see that. You can also see the platelet. The platelet is the smallest one, and then the one with the like the cream center, candy center, is your red blood cells. So the 5 kinds of white blood cells, we have the granulocytes, and these have granules in their cytoplasm. And it's interesting, platelets also have granules, and those granules are what help them when they're doing their clotting, and we'll talk a little bit more about those. And the granulocytes are your fill family, neutrophils, eosinophils, and basophils. The type of leukocytes without granules, those are your lymphocytes. Monocytes, remember, once your monocytes have been formed, when they begin traveling, they become the macrophages. So plasma contains a lot of substances. As we said, the electrolytes, clotting factors, protein, lipids, everything goes into there. They transport most of the substances your cell are going to use. If we centrifuge our plasma, we remove the clotting factors, and it's now called serum. And serum is important because we're going to talk about our serum proteins and our serum lipids. And this was really kind of a cute picture, I thought, so I thought I would share it with you. And you can see the white blood cells and the platelets don't make up very much of anything. But then you can see the red blood cells and then the plasma up at this particular point. And then the platelets are down here. The platelets are really the smallest ones. If you look at the size of the white blood cells compared to the red blood cells, the white blood cells are much, much bigger. So then the question comes up, well, why do we have blood? What does blood do for us? If you remember, it transports oxygen and CO2. Now, one of the questions I ask on occasion is, okay, where does the oxygen go and where does CO2 go? And a lot of times I get, well, the O2 is taken to the lungs and the CO2 is taken to the cells. And I'm going, not quite. Let's flip those a little bit, okay? So remember, blood is going to transport the oxygen to the cells. It's going to pick up the CO2 as the waste product because the majority of your CO2 in your body is from metabolism, and that's your waste product, and we're going to carry it back to the lungs. You also have your ions, sodium chloride, bicarb, just 3 of them, food molecules, glucose, lipids, and amino acids. Remember, your food molecules are also processed in the liver, and we're going to talk about that in chapter 18. There's some of your waste, urea, your hormones, and remember, your white blood cells are your major infection fighters. They're out there to see what's going on and keep you safe as they can. So then the question comes is, where are blood cells formed? And if you remember, all cells are produced in the bone marrow, and they arise from one stem cell, and that's the pluripotent stem cell. And you guys know that there's stem cell research going on. This country doesn't have quite a track record with it because of the ethical issues surrounding it here in the U.S. They do quite a bit of the research over in Asia and Europe, okay? I remember that the stem cells are very rare. They're attached to the osteoblasts, and we produce these cells basically by mitosis. Remember, mitosis, you get 2 and 4 and 8, and et cetera, and so forth. The type of cell that's going to be produced, remember, is that negative feedback system. If you don't have enough red blood cells, then your cytokines, your hormones, whatever, are going to activate your kidneys to produce erythropoietin. And when they do, now we're going to produce more red blood cells. If we don't need that many red blood cells, then we're going to turn some of that red marrow into yellow marrow. And yellow marrow doesn't produce blood anymore. It's actually a fat storage area. And that fat that we sometimes is there to help us with our bones, producing our bones and taking care of us, okay? However, if the red blood cells need assistance, then remember that the yellow marrow can turn back into red marrow and actually produce red blood cells. The other thing to remember is your red blood cells are in some of your longer bones, and the yellow marrow is in the longer bones. You'll also find it in your skull, your shoulder blades, the vertebrae, the sternum and the ribs, the humerus and the tibia, and all of those other places. More so with kids than with adults, because as we become adults, the production of the red blood cell actually slows down in those areas. And this is just a nice little diagram. There you can see the stem cell, the lymphoid. You can see your B and T lymphocytes, where they come from. There's the myeloid stem cells, the erythroblast, and then the megakaryocyte. The megakaryocyte is where the platelets come from. Hematopoiesis is the process of producing blood. Remember, at this particular point in time, that as the red blood cells are forming, they lose their organelles. The ones that don't and leave the bone marrow are called reticulocytes, and you have like 1.5% of reticulocytes floating through the blood at that particular point. Once the organelles have left the reticulocytes, now you have the mature red blood cell. One of the questions that you see every now and then is, what can you say about the nucleus of a mature red blood cell? And the answer is, it's gone. Remember, it's squeezed out. And what happens to it, the macrophages actually take those nucleuses and they recycle the different elements that are in there. The other thing that happens to red blood cells is when they die, the macrophages also recycle the hemoglobin, the heme and the globin at that particular point. And remember too, the erythropoietin and low O2 levels will help also to regulate these red blood cell production. The erythropoietin is produced in the kidneys. One of the things that's interesting is that if you've had a kidney transplant, your kidneys cannot make erythropoietin again. So there you see the red blood cells, most numerous, and you can see men have more than women do. They do mature in the bone marrow, okay? Manufacture hemoglobin, so it accounts for approximately 90% of your dry cell weight. And there you can see the nucleus being squeezed out by the macro and eaten by the macrophages. Let's see here. Remember, your red blood cells live for about 120 days. What happens too, then, as I said, the macrophages are going to break down the heme and the globin. The heme, if it's not used or recycled, actually goes into bile and then become bile pigments, and they're excreted by the liver. And approximately 3 million red blood cells die and are scavenged by the liver every second. Okay. And something that's kind of interesting too is the marrow produces about 200 billion new blood cells daily. So if you sort of work it out together, you can see about how many are being produced at this particular point in time. So we have different types of red blood cells. There's the normal one. You can see sickle cell. Remember when sickle cell is acting up, very, very painful because they look like sickles, okay? And then you have other ones that aren't quite as sufficient as they need to be. Now, something that's interesting is the capillary. The capillaries are like 5 microns or so, and the red blood cells are like 7 microns. And in order for the red blood cells to get through the capillaries, they have to go in single file and they have to be able to be bent over. Otherwise, they're not going to be able to travel through the capillaries. So remember that your red blood cells, we carry oxygen from the lungs to the cells, CO2 back to the lungs. If you have low red blood cells or amount of red blood cells, it's anemia, okay? Most common type of anemia in the world is iron deficiency. And that causes a number of issues for folks. And sometimes people have to take iron to make up for them. There's different lab tests, your MCV, your MCHC, and your MCH. MCV is mean corpuscular volume. That means do you have enough red blood cells? MCH is mean corpuscular hemoglobin. Is there enough hemoglobin at this particular point? And the MCHC is the mean corpuscular hemoglobin concentration. Do you have enough where it needs to be at that particular point? Is the concentration of both. Okay. And basically, anemia then comes from the body is not making enough hemoglobin. The body makes the hemoglobin, but the hemoglobin doesn't work right. Or the body does not make enough red blood cells. The body is breaking down the red blood cells too fast. It will also do it. And there's some indices that you can look at to see what's going on with those red blood cells. You can have small red blood cells, pale red blood cells. The average size of a red blood cell may be decreased. So it just depends on what's going on at that time, and you can take a look at all of those. If you have too many red blood cells, it's polycythemia. One of the polycythemias that I mentioned, you'll probably hear again, is polycythemia vera. We don't know why this happens. All of a sudden, the body starts producing a number of red blood cells. We see this more in males than we do in females. What happens is, if remember, we're producing so many red blood cells, we have a problem at this particular point because now the red blood cells can start clumping. If they start clumping, they can form clots. If they form clots, now you can end up with a stroke. And so what has to happen is these folks are on medications. They also have to go into the lab and they have to remove the blood into the hematocrit into a level where they're comfortable. Now, it used to be that we would allow your hematocrit to get up to about 51%. Remember, it's about 45. We let it go to about 51. The literatures now say maybe 52% is okay. But you definitely have to watch it because you can run into some issues with it. So this is just a little reminder of where all of this stuff comes from. There's your blood. The erythropoietin's being made by the kidney, gets into the blood flow. It sends the message to the yellow bone marrow if you have to convert it to red, or to the red if there's enough of it. You're going to see some erythrocytes being produced. They get back into the blood vessel and then they flow on. And it's interesting to watch that. After 120 days, the RBC breaks down to hemoglobin, and globin is your iron. Just remember that, okay? And the liver helps get rid of that bilirubin. Because I remember bilirubin is from the breakdown of the red blood cell. And this shows you how this happens at this particular point. We are a really good recycling plant. With your white blood cells, there's like 4 to 10,000 per microliter in the body. Remember that they sometimes will float around. If they do, they're there to be called upon if there's an infection or something is going on that has to be handled by them. They are part of your immune system. If you look, the ratio of red blood cells to white blood cells is like 700 to 1. Now, one of the books tells you that they live for 13 to 20 days. There's another book that says they live a little bit shorter. When they're circulating, they're not going to live any longer than 20 days. Your macrophages, though, when they leave the bone marrow, they go ahead and they're stored in the liver and the spleen and the lungs and various other places. As long as they're not circulating, they can live months and sometimes years, and they're just there patiently waiting for you when you need them at this particular point. So here's your leukocytes, the white blood cells. Remember, you have those with granules and those without the granules. And if you look at these, you can see the most common white blood cell you have is the neutrophils, so around 60 to 70%. Then the lymphocytes, which make your T and B and natural killer cells, is somewhere between 20 to 25%. Then your monocytes are 3 to 8%, your eosinophils 2 to 4%, and basophils are pretty rare. They're 0.5 to 1%. We're still trying to define basophils. Some of the literature and some folks will tell you that they think the basophils are the mast cells. We're going to look at what they release, and that'll give you an idea of why people say that. So remember, your white blood cells have nuclei, okay? When you're trying to figure out what the number of white blood cells that you have, we call that a differential, okay? And we'd report this as a percent. At one time, you had a count, and then report it. The new microscopes will do it for you. Interesting, you can see this picture here. This is a white blood cell who's stalking a green bacterium at this particular point. This is actually the cover of a book that's written on all about white blood cells. And it's really interesting because it describes what happens on the cell. One of the things I found really interesting when I was looking at the book, your B cells sit on the surface of the white blood cell, and they have their particular shape so that they can capture what matches their shape. And as things go by, if it matches, it gets into the B cell, and then the B cell gets rid of it. But it's almost like a radar looking to see what's going on at that particular point. So there's 5 types here. The neutrophils is one of the major defense systems. It kills by phagocytosis, and it only gets like 5 to 20 bacteria in a lifetime, which is not a lot. And part of the reason for that is its size, okay? When you look at the macrophages or the monocytes, those are big, sloppy white blood cells, and they get to eat a lot, up to about 100 bacteria in a lifetime. When we're looking at the lab report, immature neutrophils are called bands. Bands are produced when you have an overwhelming infection. And as part of that overwhelming infection, one of the things you're going to hear people talk about is now you have a left shift, okay? And that left shift is telling us that there's a major infection going on in the body and that the neutrophils are doing what they can to fight it. Some of the ways of decreasing it the neutrophils is by radiation, chemotherapy, many forms of stress. People don't realize that. And remember, when you lose those neutrophils, you're opening the body up to infections at that particular point. Eosinophils, for the most part, we know that they're there when people have asthmatic exacerbations. However, eosinophils also kill parasites, okay? These guys are cytotoxic. What they do is they go ahead and they release their granules on whatever they're going after and whatever they're killing at that particular point. And there's your basophils. As I told you, we think sometimes they could be the mast cell. And part of the reason is they function in these allergic and parasitic reactions. You see them with hay fever, anaphylactic responses to insect stings, different things like that. And what they do when they're activated, they release mediators to go and recruit other white blood cells and the inflammatory mediators to come help also. And these are your neutrophils and your macrophages. They also release histamine that says, come on, you need to come on your way, heparin to help prevent clotting, and serotonin and prostaglandins and the leukotrienes also. Remember, sometimes your prostaglandins and leukotrienes contribute to that allergic response also at that particular point. Now, it's interesting because then the question comes up is, how does the white blood cell get to where it needs to go? And it's going to basically be carried in the blood. However, what happens is once it gets to where it needs to go, there's a sensing device and everything. It takes its nucleus and it pushes it towards the front of the white blood cell. And then it uses that nucleus that's sitting up in the front to push through the fibers of the cell wall, the vascular wall. And what happens then is after it gets out, then the vascular wall basically repairs itself. And this procedure, let me see if I can find the name of it here. I wrote it down, is diapedesis, Diapedesis. So it's really kind of an interesting thing because that's basically how they do that. Then we have our lymphocytes. We have our B lymphocytes or our B cells. These are the guys who make antibodies. When we talk about serum proteins, we're going to see that they also make antibodies. Then you have your T lymphocytes or T cells, and there's 5 different types of those. The inflammatory T cells, these are the guys who are going to put out the message and say to the neutrophils and to the macrophages, hey, you need to come. We have a problem here, okay? This is a good thing, except your neutrophils and your macrophages also activate sometimes the inflammatory cascade that we see. So it's one of those things, helpful, but how helpful do you want to be? It's almost, if you remember when we talked about Burns complement, we know complement's proteins. It's there to help us, but if you get too much complement, now you're going to end up with some problems also, okay? You also have the cytotoxic T cells. Remember with the cytotoxic ones, we're going to throw whatever's in our cytoplasm at you, okay? These are the ones that kill the viruses, maybe tumor cells. Where they break them open and then they kill them at that particular point. You also have your helper T cells. These are the ones that are that you have a problem with when you have AIDS. This is your CD4 count, okay? They enhance the production of antibodies by the B cells, so that they're to help us. Memory T cells, which remain behind to help the immune system and say, hey, if this ever happens again, don't worry too long. You need to give us a call, and we can be there to help you. Okay. And then the other ones that you have are suppressor T cells. This suppresses the immune response to keep everything under control. The lymphocytes leave the bone marrow. The T cells migrate to the thymus to mature. And remember, as you age, that thymus gets smaller and smaller and smaller. Then the B and T cells live in the lymph nodes, the spleen, and the blood. And this is kind of a pretty picture of the different viruses. It's amazing how beautiful nature is, even when it's not good for us. So this is a macrophage. Like I say, they're really kind of big. And as you can see, this one is kind of chomping down on its lunch or dinner. Once they start off as monocytes, and once they live in the tissue, then they become the macrophages. Like I said, as long as they're not traveling, they can last for months or years. They can eat up to 100 bacteria in a lifetime, okay? In addition, if you remember, they destroy old, damaged, dead cells in the body. They're the ones who keep the cells clean and make sure that you don't have infections with them. They are the phagocytosis folks who keep everything pretty good for us. You're going to find them in the liver, the spleen, the lungs, the lymph nodes, the skin, the intestine, inside of all of those cells. And then if you look through the microscope, you can tell whether or not you have a normal white blood cell count or a high one or a low one, just depending on what's going on. And if you notice the white blood cells, how do you know what they are? Well, they have nuclei, remember? And if you look, the nuclei for each of these white blood cells is different, and they also stain different colors. That's why we can look at them and know what we're looking at. The other ones on there, the pale ones, if you notice that none of them have a nucleus because they all look like that cream saver candy, that is your red blood cell. Okay, so then we're going to talk about the thrombocytes. For the most thing about the thrombocytes are the smallest ones that we have. They're produced from megakaryocytes. One megakaryocyte can produce anywhere from 1,000 to 3,000 platelets. They do not have a nucleus. They do not reproduce. They only live for 9 to 10 days. They rotate or float through the blood. They're unactivated at this particular point, and because they're unactivated, they actually look a little bit round like a plate. What they're there for is to help clot blood to produce a platelet plug, okay? Your clot, remember, forms when the blood is exposed to air. And so what happens is they go ahead and they platelets sense this damage that's happened to the vessels. And as a result of that, they change their shape. They become more round, long, finger-like projections extending from the cell. They become sticky. They adhere to the cell and to one another. And what they do is they also capture the red blood cells, white blood cells floating by, and they become part of that platelet plug also. Okay. And basically, the mesh will harden as it dries and forms that clot. And sometimes we call that our scab, okay? In order to be able to do this, you have to have calcium and vitamin K. If you don't have these nutrients, it's going to take you a whole lot longer for your blood to clot. And if the nutrients are missing, you could also bleed to death at that particular point. So this is how your platelets come into being. There you can see the megakaryoblast, the different things it goes through, and then the megakaryocyte. Now, normally we see somewhere between 150,000 and 400,000 per microliter. This is normal. This is what we need to make sure that we have appropriate platelet plugs being formed. Less than 50,000, you have a danger of uncontrolled bleeding. So if you were to go in and do an ABG on a patient who has a very low platelet count, there's a good possibility that it's going to bleed longer than that 5 minutes that we normally hold pressure. So you always want to make sure you take a look at that. Make sure you understand what's going on with these folks so that in case you do have to do that ABG, they're not going to cause problems because it's not going to clot. It is decreased by certain drugs and herbal remedies, and also if you're autoimmune, you can have some problems with these too. So there you can see the top picture's a blood clot. Then you can see down here the inactivated platelet. Okay, that's what they look like, and there's your plate type formation. So I talked a little bit. I want to add something with platelets. Remember, I talked about the fact that you can have thrombocytopenia, which are not enough platelets. You also can have thrombocythemia, and this happens sometimes when you make too many platelets, and unfortunately we don't know why this happens. But when it happens, platelet counts have been known to rise above 1 million platelets per microliter of blood. And unfortunately, what happens with this that you have to be careful with, now you can start seeing clots form, and now you're going to have some issues with that also. I found that kind of interesting. So if you ever hear that, you know what's going on. Plasma, remember that's 55% of what you have in your blood. Star-colored liquid, all your blood cells are suspended in it. You can see it's 92% water, 6 to 8% proteins, 0.8% of salts, 0.6 lipids, and then glucose, which is your sugars, which is about 0.1%. Remember when we talked about absolute and relative losses? When you are dehydrated, you've got 92% water in this plasma that's going to start disappearing. And as a result of that, you're going to have a relative decrease in your plasma and a relative increase in your hematocrit. And that's when your blood becomes a little bit thicker. The other way is also if you have a lot of fluid in your body, now your hematocrit has to go down because now the plasma is relatively higher because of all the extra fluid. So as you can see, it's there to transport to and from the cells a little bit of everything that we have in our body that we need. So serum proteins are the first thing we're going to talk about. Remember, serum is plasma that's been centrifuged and the clotting factors removed from it. You have two that we concern ourselves with, albumin and globulins. There's 3 different types of globulins, but by far most, albumin is the major serum protein. It's associated with edema, decreased transport of calcium if it's too low. So there is a relationship between calcium and albumin. Decreased levels cause inadequate iron uptake, severe liver disease, malabsorption, diarrhea, eclampsia. Third-degree burns or full-thickness burns, starvation, excessive IV glucose will also cause problems with albumin. So we see a lot of edema when we're in the intensive care unit. We look at the chart and find out that the albumin is really, really low. And at that point, then we got to figure out how we're going to get the fluid back into the vasculature. And remember, you have your oncotic osmotic pressure. So if you do for chemical look at these, there's your albumin, there's your different globulins, alpha, beta, and gamma. Alpha globulins, this is your thyroxine and retinol. Remember, retinol is also vitamin A. You can buy it and put it on your skin and become beautiful. Your beta globulins are the iron transporting protein transferrin, okay? And then gamma globulins, most of these are antibodies, and they'll increase once you have an infection or an immunization. However, there are people who are born with gamma globemia, where their body is not producing the gamma globulins, so they don't have the antibodies. And what has to happen is they have to come in the hospital about every month or so, and they have to get the gamma globulin shots. And if you've not had that pleasure, it's probably something you don't want to ask for, because gamma globulin, when you have those shots, it's a very thick shot of material that we put into you. So there are some issues with it that's very painful. You also remember during the Gulf War, they were given the gamma globulin shots, and some people refused to take them. And it turned out for some of them it was a good idea, because some people did have some really bad reactions to them. With your serum lipids, this is your serum fats, and remember your fats are tied into cardiovascular diseases. Basically, high levels of it cause arteriosclerosis. These are some of your typical ranges. Cholesterol, like normal, 170 to 210, one less than 200. When you look in the literature, you see there's a lot of physicians out there who don't agree with this. They'll tell you 200, less than 200 is way too low. 170 to 210 is okay, and we should be able to function at that particular point. LDL is your low density lipids, and you can see those are kind of low. These are the bad lipids, okay? Your HDL are your high density lipids, and these are the ones that you want to have at high levels, and they really, really do help you keep you well. If you watch commercials on TV for oatmeal and things like that, it helps remove your LDL and it raises your HDL. So oatmeal is one of those good things that you want to look at. Triglycerides, these are your major fat storage area in the body. So in case you're wondering what triglycerides do, they are the major fat storage in the body. So they do help store the fat in the body. Cholesterol is actually one of the steroids. It's essential for life. You have about 100 grams in the body. Your myelin sheath is rich in cholesterol. Okay. You also need the cholesterol for your steroid hormones, progesterone, estrogen, testosterone, cortisol, aldosterone, things like that. It's also a precursor for the body to synthesize vitamin D, and one of its major uses is the synthesis of bile acids. Okay. Some people are born with high cholesterol. They give them statins, and sometimes the statins help, sometimes they don't. You can control it sometimes with diet and exercise. I actually worked with a gentleman who was not on statins. He was in Israel. He ran every day and everything, but he couldn't just get his cholesterol down. It's it's kind of sad. The other thing, as I said, cholesterol is the precursor also for progesterone, estrogen, and testosterone. We have all three of these in our body. It just depends if you're a male or female with the different levels. Quick story on the side. When I took organic chemistry, one of the questions on the final was draw the cholesterol symbol and then tell how it converts to progesterone and then to testosterone and then into estrogen. And I'm like, you've got to be kidding me. So here's the chemical nature of cholesterol. Total cholesterol, you can figure this out now. HDL plus LDL plus 20% of your triglycerides. Now, the thing you need to remember is if you're going to have your blood work done, you're supposed to fast. It used to be 12 hours. Now they're saying 8 hours. I think some of them are doing a little bit less. You know, it just depends on your lab and your physicians. However, if you choose to have a cup of coffee with a little milk, a little sugar, you're going, that's pretty good. I'm not eating anything. You can raise your triglycerides too high. And if you raise them too high, you will not be able to measure your cholesterol, HDL, or LDL. So when they talk about fasting, you need to fast. Okay? And this is something that came from one of the earlier books, the cardiac risk ratio. You can take your total cholesterol divided by your HDL, and the ratio should be 5-to-1 or less. Okay? Just an introduction to electrolytes. These are chemicals in your body that you need for body functions. Remember, when you dissolve them in water, you get ions, positive and negative. The negative are the anions, the positive are the cations. Okay? You need them for your nerve reaction and the function depending on what they're going to do for you. If you look, it's kind of interesting with this one. I saw this and I went, ooh, I got to borrow this. The total body fluid is around 50 to 60% of your body weight. Your cell fluid is somewhere between 35 and 40% of your body weight. Your plasma is 5%, interstitial fluid is 10 to 15, and then any extracellular fluid is 10 to 15% of the body weight. So you can see we have quite a bit of fluid in the body. Main electrolytes we're going to look at is sodium and chloride. Remember, sodium is your major extracellular cation. Chloride is your major extracellular anion. And remember that sodium and chloride are two mates. Wherever sodium goes, chloride follows. And when we start to talk about bicarb, one of the things that we know about bicarb is that both bicarb and chloride will fight for the hand of sodium. And so what happens in those cases, if your bicarb is going up, then your chloride has to go down. The body doesn't store excess electrolytes. This is one of the ways that we can sometimes tell that a patient may have COPD. We do their ABG, their pH is 7.39, their CO2 is a little bit high. We're not quite sure how that ties into what's going on. We look at the bicarb is now like 28, 29, and then we notice the chloride, instead of being between 98 to 108, is now at 90. Well, what you've got there is the fact that the bicarb is now combining with the sodium and the chloride, it now has to leave because the bicarb is going to remain elevated because of this COPD or neuromuscular diseases that you have. Magnesium, we don't have too much of that. That's more intercellular. Calcium and potassium is one that, not potassium, calcium, phosphorus is one we're going to talk about. And then the last one is potassium. If you remember, potassium is the major intracellular cation. There's actually more potassium intracellularly than there is sodium extracellularly. However, for potassium extracellularly, it's only somewhere between 3.5 to 5 milliequivalents per deciliter or per liter. So you can see here's some of the values. Calcium, depending on the last names, make sure if you see these on quizzes, exams, boards, or something like that, take a look at the last name, okay? Sometimes your electrolytes are reported in millimoles per liter. Sometimes the millimoles are very close to the milliequivalents per liter. I'll see if I can find, I think I had that at one time, and I'll see if I can find that value again. Milligrams per deciliter are much more than the milliequivalents per liter. So make sure you take a look and understand what that last name is, okay? So there's your chloride, your potassium, magnesium. It's like I said, magnesium, there's not much, 1.5 to 2.5. Sodium, somewhere around 135, 145. Your book may have slightly different numbers. When you go to clinical, if you look in the labs, you're going to see slightly different numbers. They're not extremely off. Sometimes sodium is like 136 to 146. Sometimes potassium, 3.5 to 5.5. Just depends on the lab and where you're getting these values from. There's your phosphorus. Phosphorus, as you can see, 2.5 to 4.7 milligrams per deciliter. Milliequivalents, 1.8 to 2.3. So when you're looking, phosphorus and magnesium are pretty low. So if you break them out, here's your extracellular fluid, intracellular fluid. You can see there's your sodium, major extracellular cation. Potassium, very little in the extracellular, major intracellular cation. Calcium, for the most part, you can see very little, and on both of them. Magnesium, more intracellularly than extracellularly. Chloride, major extracellular anion. Bicarb, a little bit more extracellularly than intracellularly. And as you can see, phosphorus, more intracellular than extracellular. So here's your fishbone charting. If you ever look at these, there's your sodium chloride, your BUN, and the glucose over your potassium, CO2, and your phosphate.